I'm Professor Helen Cross, the Prince of Wales Chair of Childhood Epilepsy at University College London and Great Ormond Street Hospital for Children. I see children with alternating hemiplegia of childhood in my day-to-day clinic, and in particular we have been collecting a cohort of patients together with Queen Square. I have known about AHC for a very long time. I trained with Professor Brian Neville. I arrived at Great Ormond Street Hospital in 1990 and worked as his registrar prior to doing my PhD and subsequently becoming a fellow consultant. Brian has been has had a firm interest in AHC for a very long time, and I have been seeing patients since that period of time. AHC is a complex neurological disorder that can have several different manifestations. One of the prominent manifestations is intermittent weakness of one side, or an inability to move one side, or indeed intermittent stiffening that can last quite a period of time and that is usually alleviated by sleep. There may also be manifestations of epileptic seizures, and a degree in time of developmental delay. There are different aspects to the treatment. There's the treatment that we may consider to give on a regular basis to try and reduce the number of weakness episodes, and medications that may be utilised for this includes flunarizine, and this is given on a regular basis rather than on an intermittent basis. If there are manifestations of epileptic seizures, then we would use anti-epileptic drugs, and topiramate can be particularly effective. But also what's equally important is treatment of the actual episodes themselves, attempts to curtail the episodes themselves. And for that, that may be an individual basis of what medication may be best, but certainly benzodiazepines such as buccal midazolam or rectal diazepam, perhaps buccal medication if preferable, to try and get the children to sleep. Sometimes oral benzodiazepines are used if they retain their swallow, but then they find if they're treated early, they can curtail the episodes, often by putting them to sleep. And the other aspect of treatment is, often part of the intermittent episodes can be quite painful stiffening, and we've also found that some of the movement disorder medications given on a regular basis can alleviate that. What we don't know is treating the actual cause. What we're doing is treating the symptoms and trying to alleviate the intermittent weakness episodes. And so we're still at the phase of treating the symptoms rather than actual treating the underlying cause. It is very common for children to come to neurological assessment having been misdiagnosed. Either misdiagnosed as having epilepsy, because that's the easiest diagnosis to give, with intermittent paroxysmal episodes, intermittent short episodes, and often the eye movement problems that we see in the first year of life. People can only explain as epileptic seizures when actually there's a paradox, because they describe that they're still aware and they're still with it. And they go on for a long time. So that doesn't really sound like an epileptic seizure. Again, when the movement problems occur, again, either seizures or intermittent strokes, when actually they fully recover. So these are common misdiagnoses. And of course, because some of the episodes may be alleviated by regular anticonvulsant medication, that sort of compounds the misdiagnosis. I think there are different stages that we go through with many of the neurological diseases, and at the present time it's very exciting that we're getting so much more information about causes. It doesn't only relate to AHC, but it also relates to other rare neurological problems. Getting a gene is the first step. What that gives us information, as much as we have a gene, and there are different genes as well being determined, it's not one gene as a cause for all of the different AHC. By having an understanding of that gene, we understand what that gene does, what protein it codes for, so that we may be able to target that particular gene as an alleviating symptoms in the short term. And then ultimately the issue then becomes, can we find a cure? And as far as we have at the present time, with these abnormalities in the brain, it's very, very difficult to target a treatment. I'm not saying it's impossible, and in the long term that may well be possible, but at the moment it's not really there. What we know is that AHC, 75% of AHC that's been tested so far may be due to one particular gene, but we also know other neurological problems may be associated with abnormalities in that gene. So what's key is looking at the gene and looking at the abnormality, i.e. the clinical manifestation, and putting those together with increasing numbers. So that, and we've seen this in other disorders, that different types of epilepsy may, for example, be caused by a mutation of the same gene. And it's the different function of that gene that gives the different manifestation. So I think, yes, there may be other, even though it seems a very specific phenotype, there are different ends of the spectrum, and it may be, are they all the same disease, or are they different diseases all within one phenotype? If we find a solution for AHC, it may well help other disorders, not only from looking at the gene, but also looking at the way we've got there, and looking at the way we've looked at the protein, that it manifests, what it codes for, and also looking at the way forward with treatment. Just as looking at causes of other diseases and the way we go with other diseases may indeed help AHC. Cannabidiol is a pure form of cannabis. Cannabis, there is the psychoactive component, which is the THC. Cannabidiol is much purer, and in the form that's being used in epilepsy, has a very small amount, if not a non-existent amount of THC, so it's felt to be much safer. It has been trialled in children with complex epilepsy, initially on an ad hoc basis with various compounds that were home produced. So you didn't know the concentration, and there's been a lot of reports of dramatic improvement in seizure frequency. Of course, another form of the compound is used in movement in cerebral palsy for spasticity, and that's been under trial in a different form. There's no doubt that there appears to be a benefit in epilepsy, and there appear to be reports, although not actually proven as yet, of associated benefits in both behaviour and cognition. So there's something happening within the brain both to reduce the threshold for seizures, or raise the threshold for seizures, and also maybe have other benefits in cognition and behaviour. I think, when we look at it, it's difficult to know exactly what the mode of action is. There's a lot of animal studies to try and look at that. But I don't think the benefits are limited to epilepsy. They may be benefited to other paroxysmal disorders as well, particularly with the issue of the link between the benefits in spasticity as well as the benefits in epilepsy. So I think it's this compound that we have to think about, to trial it, to look at it systematically, and could have benefits in AHC. I think what we have to bear in mind is it is a medication just like any other new drug. And it does have side effects. And I think the more it's used, the more we realise it does have side effects. Nothing very severe has been reported to date, but I know now that there are reports of decreased appetite, gastrointestinal symptoms, somnolence, sleepiness, and even increased seizures have been reported. Even though, on the other hand, the seizure-free rate has been higher than you'd see in other open-label studies. So this is in epilepsy. So I think we don't know the issue with regard to safety, which is why it is much better to trial it in a structured way. The problem that we've had in some of the anecdotal reports is that with self-produced compound, it's not a consistent amount of cannabidiol that's in each product. And therefore, if you're not giving a consistent amount to an individual, you can't monitor the effects that reliably. And therefore it's much better to go into a trial where you've got careful monitoring of blood, careful monitoring of benefit, careful monitoring of harm, than it is to try anecdotally and that monitoring is not going on. AHC is a complex and rare disorder. for which the biggest experts are parents and families of those who have a child with AHC. And as the time goes on, of course, children grow up into adults. I think it's for the professionals to learn from the families as well as the other way around, for us to raise questions from clinical practice, just as has done already. It's a very exciting time. We've learnt more in the past 3 years than we'd learnt in the previous 20, but there's still an awful lot more to learn. And I think concentrated effort on the part of parents to come together, on the part of professionals to collect that clinical information together and to have concerted efforts with regard to clinical trials is the way to go forward. AHC is a disorder that we've known about for a very long time. It's been clinically described for a very long time. So to get an actual cause of many of the cases is a real scientific breakthrough. It gives us much more scope in order to look at what the cause is, the way forward with treatment, and then also gives us more, in those cases that are negative, they're more likely to teach us even more than those that have actually got the single gene that's been discovered. If I had unlimited funding, I would probably go in one of 3 directions. Certainly with the knowledge of the ATP1A3 gene, and I know centres are already doing this, then you want models of various different types to actually look at the clinical manifestation, look at the cells, look at various abnormalities and ways forward that you might go with treatment. There is also looking at the function of that gene to look at the protein that is in defect, what the issue is, and where else it's manifest in the body, to know what else we need to be looking for. And then the third thing is treatment. By looking at the function, what treatments have we got already that we can go forward with? What are the components of treatments that work, that really are working, and how are they working? And this may sound like a huge programme, but with unlimited funds, it's a programme of work that could go a long way. One aspect of research that's also as important as looking at those that are positive for the ATP1A3 gene are those that have not got that gene. What is the abnormality? Is it a range of genes? Is it a combination? Is it the genetic background that may influence why they are like they are, or have the clinical? But looking at the genotype-phenotype is a way we can go forward with diagnosing the children more easily. The children who are negative are going to teach us even more about the disorder,
and therefore more difficult to get
it's much more difficult to get to. But that's where the greater funds are required, because it is quite a technological challenge to give answers quickly. You could see how long it took to get the first gene. Then some genes are coming through in the negative group, but everybody knows that we can map the genome. Mapping the genome, so to speak, is not complicated. It's mapping what the abnormality is and what the problem is that's difficult. It takes a lot of technology, a lot of manpower in order to do that in just even one individual.